Our next speaker, Eric Donnenfeld, is clinical professor of ophthalmology at New York University. He'll present his work on a new modular curvature-changing fluid optic accommodating intraocular lens. Eric, can you shorten the name just a little bit for all of us?
I don't do anything short.
Okay, very good.
Thanks, Ed. And I tell you, Scott, unbelievable presentation. That was fantastic. I'm going to present on a new accommodating IOL. I think this has tremendous potential. I'd like to acknowledge my co-authors, but more specifically, I'd like to acknowledge the engineers and particularly Ram Rao, CEO of LensGen, whose tireless inspiration and driving force has really gotten us to where we are today. I do consult with the company LensGen that I'll be speaking about today. I think this speaks for itself. For all you millennials out there who do not know the pain of presbyopia, this is something that's coming in your future.
Not really. It looks like it says 11?
It is 11.
That is? No way. It can't be.
So many of us, particularly those of you sitting in the front row here, know that accommodation decreases with age. In your 40s, you begin to lose lens accommodation. By the time you're 50, it's significantly lost. There's a decrease in night vision. In the 60s, there's usually some early nuclear sclerosis, and your vision really becomes a problem. So what is the need for a management of presbyopia? Well, it affects 1.7 billion people worldwide. There are 27 million cataracts performed around the world, and we need an IOL that corrects presbyopia and astigmatism, that gives better post-op stability, high-quality optics, is upgradable to any future advanced technologies. So in my estimation, what would I say would be the ideal IOL? Well, dynamic continuous presbyopia correction without splitting of light, astigmatism correction, stable post-op refractions, more reliably hits emmetropia, mitigates posterior capsule pacification and posterior vitreous attachment, is modular and upgradable, and has the potential to be a platform for both drug delivery and advanced electronics, which is why I'd like to introduce you to the Juvene lens. The Juvene lens is a biomimetic lens. It really mimics the natural crystalline lens. It's capsule filling. It has curvature-changing fluid optics. It's modular with two pieces, and it fits nicely through a small incision implantation. This video shows you the basis of the lens. It's a two-piece lens, starting with a base lens that's inserted into the capsular bag. And then once the base lens is inserted, we take the fluid lens, which is the accommodative portion of the lens, and we insert that into the eye, and it fits right nicely into the base module lens and is snapped into position using 3 stanchions to make sure that it's held in place. How the lens works, it works exactly the way the natural crystalline lens works with contraction of the ciliary muscles. There is accommodation. The base lens fills the capsular bag. The accommodative portion fits inside and is snapped into place, and when the ciliary muscles contract, you can see relaxation and bulging of the silicone optic, which causes near vision. Standard IOLs present significant compromises. The compromises include effective lens position shifting and tilting. When you put a very thin lens into a large capsular bag, by definition, the capsular bag has to contract, and very commonly it will tilt, it will shift. There may be rotation of the capsular bag as well, and we all know that probably the most common complication of cataract surgery is posterior capsular opacification. Finally, because the capsular bag moves forward, the vitreous base comes forward, resulting in floaters and possibly retinal detachment. Having a lens that fills the capsular bag resolves many of those problems. It gives us a stable, effective lens position, stable refraction, minimal IOL rotation. We have basically no posterior capsule pacification, as we've learned. When the capsular leaflets are held apart, the capsule does not opacify, and because the capsular bag maintains its natural filling, there's less vitreoretinal traction at the end of the day. So the platform is the base lens. You can put an accommodating lens, which we call the Juvene. You can put a monocular toric, a fluid toric, a trifocal. You could add drug delivery and electronic sensing all at the same time. My surgical experience took place in the Dominican Republic, and I'd like to say a special thank you to Juan Baye, who's one of the finest gentlemen and one of the finest surgeons I've ever met. His staff was extraordinarily welcoming on our trips to the Dominican Republic, and he allowed me to participate in his OR, and here you can see Juan doing superb cataract surgery, removing the lens in a normal fashion, making a normal 5mm capsular rhexis, and then cleaning the back surface of the anterior capsule. At this point, he stepped aside and let me take over to implant my first Juvene lens. I apologize for the slow nature of my insertion, but this is how the lens is inserted into the eye. It actually can be done a lot faster than this, but I wanted to show you the complete lens insertion. The lens base is made of a very, very pliable silicone. It's extremely soft, very manageable, and the engineers have had 4 or 5 different iterations. Every time the silicone becomes softer and more pliable, the lens becomes more effective. Once the lens is inserted into the capsular bag, it's centered, and you can see the 3 stanchions there that hold the accommodating portion of the lens in place. The second optic is now inserted into the eye, and once this is in the eye, this contains a silicone sleeve filled with silicone, and we're using different viscosity silicones to achieve more refractive correction. And once it's inserted, it's just simply snapped into place, and as it's snapped into place, the lens centers well, and you've completed the surgery. And that's basically real-time implantation on my first case, and I think it's well within the realm of every surgeon, and all done through a 3mm incision. Viscoelastic is then taken out of the eye, and there are fenestrations in the base lens that allow the viscoelastic to be removed from behind the IOL. So when I first started implanting multifocal IOLs, I see my friend Dick Lindstrom, who's got more experience than I do. We started doing these maybe 20 years ago, and at that time I thought this was a wonderful innovation, but I always thought that by this time, 2019, we would have moved past multifocality. Splitting light, we all know, increases glare and halo. It provides quantity, but not quality of vision. And while multifocals and EDOF lenses have gotten significantly better, the holy grail for all of us is a true accommodating IOL that really does not split light and gives us the ability to see distance and near, which is why this study is named the GRAIL study. 2 international sites, 44 eyes, multiple surgeons, and I'll present the earliest data from this trial. We plan on 1-year follow-up. I'll present the 1-month data. We have previous generations of information, and we've been doing this surgery now for 4 years. So this is the early 1-month data. You see the blue line, which is the Juvene lens, showing 2.5 diopters of accommodation, which is actually better than the EDOF lens. You see the gray line, which would be a monofocal lens. So this lens certainly significantly outperforms our EDOF lenses today without splitting of light. And when you perform binocular surgery, the defocus curve even gets better, as you would expect. Visual performance is very good. Best corrected distance vision is 20/20 in 85% of patients, and certainly better than 20/32 in all. Patients got excellent intermediate vision, and even at near, at 40 centimeters, half the patients were able to read 20/32, again without the splitting of light that you see with other multifocal and EDOF lenses. The results were very close to emmetropia with a standard deviation of 0.38, and this is attributable to the fact that there's no deviation of effective lens position because the base lens fills the capsular bag, and you don't have to worry about that variable. We have 1-year follow-up on the previous generation of lenses showing stable effective lens position going out for 1 year. And patient satisfaction, which is always the most important concept in any new IOL, is excellent. There was absolutely, in a directed questionnaire, no glare, no halos. There were 2 patients who had very mild monocular starbursting, which is not not a problem, and the rest of the problems we see with presbyopic IOLs were not seen in this trial. With 4 years of follow-up, we have no posterior capsule opacification, and we think that this is a significant advantage as well. In conclusion, I'm excited about these early results. I think the Juvene IOL is well tolerated. It can be inserted through a very small incision. It's been proven to reduce capsule opacification, vitreous traction. It fills the capsular bag and has an exchangeable platform. Early results show reproducible 3 diopters of accommodation. Long-term results we'll still be looking at, and we hope to present them very soon. And we're very excited that we have the final lens design that we're going to be taking to the FDA for trials that will begin this year. Thank you very much.
Thank you, Eric.